And welcome to the Paramedic AF show. I'm Daniel.
And I'm Michelle. Eating my snacky. Don't mind me.
Yeah, her crack. I told her to say no to drugs, but she wouldn't stop.
Okay, how can you say no to everything bagel cashews?
Yeah. Anyway, good to see you guys. It's only been a week, but it feels like it's been longer. I don't know why.
Well, our last one was almost 2 weeks away.
Yeah, but like since the very last one we did.
I don't know.
Yeah.
Oh, well.
It's been a week.
I would say a lot that.
Yeah. Okay. Anyway, I know we skipped a call review last time, but Michelle's had some interesting experiences. So, as always, I don't get much like consistent good shit anymore. Like, it used to be very regular. I get cool stuff, interesting stuff, whatever. Now it's like nothing.
You just want me to jump right in?
Yeah, why not? Go for it.
So I would be curious to hear what y'all think this is. I am waiting for a patient condition follow-up because I want to know what the actual diagnosis was. So I was dispatched out for a 36-year-old female, and the call note was very general. It was just sick person, altered mental status. Patient is 2 weeks postpartum. Okay, so I'm already thinking that was it. So I'm already thinking down literally everything. I mean, the gestational diabetes, complications, preeclampsia, eclampsia, hemorrhage. I mean, all of the things. So go to the call, and I'm getting a truck that is like 30 plus minutes away from me. So arrive on scene. I have a student with me, a paramedic student. We go, and of course, it's on the second floor of an apartment complex. Luckily, Mama was like teeny tiny. She was like maybe 100 pounds, 120 max. She's just kind of laying on the bed, like in fetal position on her right side, just kind of, just like literally just mumbling. Her husband, all the kids, and her best friend were on scene, and they were telling me, oh, she's been altered. She had a C-section 2 weeks ago. It was her first C-section. And so I just started, my paramedic students started. I do have to say, we're going to talk a little bit about like education and educating our students as well. So my paramedic student was doing the basic, like, when did this start? Sudden, gradually, are you in any pain? Stuff like that. We take a full set of vitals. Heart rate is like 70 and steady. BGL was 94. Initial blood pressure was like 120 over like 70. It was near textbook perfect. Temperature was normal. Did examine her C-section scar, and being 2 weeks postpartum, she still had like the surgical glue on it, but there was no pus, there was no redness, no tenderness. Abdomen was soft, non-tender, non-distended. She was having the normal postpartum bleeding, but no like excessive hemorrhage. Her color was good. Warm pink fuzzy. Warm pink fuzzy.
I'm telling you, when I've touched my first dead body, I was like, I get it. Live people are fuzzy.
If you haven't listened to that podcast, it's only on audio, but it is a very good one where we talk about fuzzy people and a bunch of other stuff.
Pretty sure it's in the title, live people are fuzzy or something.
Yeah,
like that.
It is in the title, so you'll just have to go back and scroll. Anyways, so there came a point where my paramedic student just kind of stood back and looked at me. She's like, well, the monitor looks good. Oh, her oxygen was like 98% on room air. My student looked back and she looks at me and she's like, well, the monitor looks good. I have no reason why she's altered. I guess we're just gonna wait for the transport truck and go. I was like, sweet baby. So I looked at the husband and the best friend, and I'm like, I need to ask you some more questions. When was she last seen normal? And thank goodness my student was able to catch a clue, and she started doing a stroke assessment on the patient. So I start getting a more extensive history on the patient than even my student got related to OB and even general medical history. So the patient has no medical history, no pertinent medical history. She's never been diagnosed with anything. She does go to the doctor regularly. She is gravida 4, para 3 with 1 miscarriage. So 4 pregnancies, 3 live births, including the C-section. This is her first C-section, and then she had 1 miscarriage. She was sent home with Colace for stool softener, ibuprofen, and Percocet. And I was like, okay, mind you, her pupils were equal round reactive about a 4. But I was like, let's still see, the Percocet vial. She hadn't taken any of them. All pills were accounted for. Well, so I started asking the husband, more information about it. There were no complications during delivery. She was discharged pretty quickly. I asked even about breastfeeding. She's an undersupplier, so she's been supplementing with formula. She's trying to pump, but she's probably not going to continue. So I was like, okay. Mom and dad have been alternating, so sleep deprivation in theory is spread out. She's never had any issues with postpartum depression or psychosis. So, we're slowly trying to work down our differential list. And I asked if anything had changed recently. And the husband told me that the day before, she was complaining about blurred vision, like really blurred vision in her left eye. And she does not wear glasses or anything. So, it's a sudden vision change. No changes in her eating or drinking, urinary bowel habits. She had one UTI while she was pregnant, not since, no symptoms. I was like, okay, so I'm feeling kind of strokey at this point, if we're being honest. So,
I'd be stroking.
I mean, at this
what
point,
I'd be
yes.
doing.
Oh my God, that song. So, we're doing the stroke assessment, and she can't follow commands at all. Like, when I was trying to see her pupils, she kept looking down and closing her eyes. So I was trying to open her eye, and you tell her to do something, and she just either kept mumbling nonsense words. The only sentence that she actually said the entire patient contact is, I'm sorry. And it was almost like a stutter, I'm sorry. But I mean, there were clear words, no slurred speech. The only thing that we really noticed, because we couldn't get her to follow commands at all, is she did seem to favor her left side. Like, the left side was stronger. She kept wanting to lean to the right, even when we helped her sit up in the bed. I was like, okay, can't follow commands. Surgery 2 weeks ago. We're looking at a couple different possibilities of stroke causes, if that's what this is. So I find out where my transport truck was, and they were like, oh yeah, we're pulling in, blah, blah, blah. Well, I guess we were agitating the patient. And she went ahead and stood up on her own, and started walking. And I know a lot of people are going to argue that, if a patient's having a stroke, then they're going to, with favoring the left side, they're not going to be able to walk. Well, you can have weakness without complete deficit.
Mm-hmm.
And she was walking, but she was leaning as she walked, and she kept dropping.
So she can start going in a circle.
The way she was leaning, she probably could have. So she was already up walking towards the front door because her husband had just come in. He had brought in, I can't remember if it was his mom or her mom. So I was like, dude, we're already in motion. Let's not get her to stop. I mean, she's 100 pounds. I could granny scoop her up in a hot minute. Like, we're fine. So the transport truck said they were pulling up. I was like, cool. I called over the radio. I said, just get your stretcher out. We need to go. So we get her down the steps. She is significantly leaning to the right, won't follow commands, just mumbling at this point. We get her onto the stretcher, and the EMTs, we had an experienced EMT, and then we had a brand new baby driver that was with us. And, we were trying to get demographics and get all this stuff. And we get the patient loaded in the truck, and I look at the EMT. I'm like, all right, baby, I'm ready to go. Of course, I gave him a quick rundown of what's going on. He's like, okay, cool. I'm driving with you. I got you. So I go ahead and call and report. And I would like to think that I'm pretty good at giving report. I usually do. I don't follow the missed assessment, but I mean, it's pretty much like, hey, this is Michelle with so-and-so. I'm coming into your facility emergent with a 36-year-old female patient, reportable chief complaint is altered mental status. She's 2 weeks post-op from a C-section. She's postpartum. And I went ahead and let them know that it was a neuro alert. I was like, look, she's altered. She can't follow commands. She just had surgery, and I can't rule it out. This is one of those no. And I even told them, I was like, no pertinent medical history at all. Gave them full set of vitals. Well, so then the call taker asked for a race score, and I was like, she can't follow commands. I can't complete a race assessment. They're like, oh well, if you're gonna call a neuro alert, we need a race score. I was like, okay. I mean, I guess a 1, because like the like right-sided deficit is like the only thing that like I can positively like sort of identify without her like actually following commands, because that's something you can observe just because the patient got agitated and was walking. So I was like, she's obviously favoring the left side over the right. And they're like, okay, see you in, such and such. Well, we get to the hospital, unload her, and they had her in a hall bed. And I just looked at the nurse. I was like, this, like, no, I understand this is like non-specific, but like she cannot go in a hall bed.
Yeah.
So they take her to one of the, I guess you could say, quote unquote, like trauma bays. This is a smaller hospital, but they are stroke accessible. And they asked for the report. I give them report, full history, like literally everything that I just told you guys is what I gave them at bedside. Well, they're looking at the patient, they're starting another IV, they're looking her up in the thing, and no doctor comes. And I was like, hey, what's going on? They're like, this isn't a stroke. We cancel the neuro alert. That like, no. So, and I mean, I was getting attitude from everybody. Like, I mean, the call taker wasn't happy about it. I was like, dude, I can't give you a race score because she's not following commands. Like a 1 if I have to, like, if I had to pick a number.
Yeah.
If I had to pick a number. The nurses were giving me attitude, and I was just like, hun, this is one of those cases that I don't have enough equipment in the field, and I'm telling you, she has risk factors. Even if it's not a stroke, something is wrong for this lady to have no medical history. No evidence of drugs. And honestly, as I told them more stuff, like even that we counted the Percocet vial or pills, they did seem surprised at that. Well, so I went back out to the truck and I came back in. I swear, not even 5 minutes later, because I saw a crew that I needed to ask a couple questions about something that we had done earlier. And all of a sudden I hear a bunch of commotion and stuff. So I walk down the hall and I peek in her room. She's gone. Bro, she's gone. So I start walking back out like towards the triage area because that's where the crew was. And I saw one of the nurses that had, one of the worst ones that had given me a really fucking bad attitude in the room. And I was like, hey, I see she's not in her room. Did she go to CT? He was like, oh my God, she started getting so much worse and like talking out of her head and like was lethargic and like wouldn't look at anybody and like was leaning to the right. And I was like, oh my God.
No they suddenly got worse. That's the EMS/emergency room equivalent of, well, I just found them like this.
I done fucked
or
up.
This isn't my patient, or we just did shift change. Okay, suddenly got worse. Actually, no, the symptoms were the same. You just didn't take it seriously walking in the door.
Well, and I even told them that like she was mumbling on scene, but during transport, literally she just wanted. And I mean, you could arouse her, but she stopped talking, like during transport.
Well, this is why I'm thankful for one actually hospital system that we frequently transport to. Their call takers are paramedics. Mm-hmm. So you're able to actually have a conversation with them and say, hey, like, I know that. Because I've had that happen. Most of my stroke alerts, I can't get a race scale on because they're altered in some fashion. Mm-hmm. And I'll tell them, I'm like, look, I can't give you a race score, but I am telling you this is neurologically induced AMS mm-hmm. and needs to have a full evaluation, needs mm-hmm. a full neuro workup. It could be I could be completely wrong, but there's a smoking gun here somewhere.
Well, and that's fine, because at that point, even if I'm dead ass wrong, there's nothing to this lady and she just had surgery. Mm-hmm. She needs a physician. She doesn't need to sit in the ER for the next 4 hours waiting for a physician. I mean, sure, she probably would have been seen faster, but that's not the point. She is the perfect candidate for either an amniotic embolus or, a blood clot, because, everybody, I think, is taught that you can get blood clots that travel around, even if not to your heart, but to your brain after surgery.
So the moral of this story is, obviously, we always need to do our best with communicating the hospital, but you're going to have times where even if you communicate everything well, you're still going to be basically looked at like, okay, really? And the humility needs to be there to say, hey, you know what? You, person who brought them in, you were actually right. And we should have taken it seriously. So not shitting on the whole hospital, just that's more of a problem there mm-hmm. and is part of the cultural problem between disciplines that needs to be addressed.
Well, but also, when I was talking to my student, not just on scene, but after we had done everything en route to the
En
hospital,
route?
bite me. En
Mm-hmm.
route to the hospital, we had some time, and I was, just asking her questions about her assessment, about what she was thinking. I mean, we had talked about a stroke, and I asked her, I said, okay, so why do you think, we called a stroke? She's like, oh, well, she's altered, and we don't know why, so we're just going to call a stroke on everything. And I was like, I mean, I mean, no, no, you have to do a full assessment. And then I asked her, I said, so why are we transporting emergent? Oh, well, it's okay to just transport whatever you need to emergent so you get there faster because of, X, Y, and Z. And I was just like, but no. And she was like, oh, well, we do that at my service and we do, blah, blah, blah. And I was like, honey,
Your service is wrong.
I mean, yes. Well, and it kind of comes down to we need to make sure that we're thoroughly educating people. And I don't care how many instructor certifications you have if you're not keeping up with medicine and teaching appropriately, and you're taking the lazy way out. Your certification or your professional portfolio doesn't matter. I mean, there were several times where I was talking to the student. We had a lady that was highlighter yellow with no liver history or ammonia history, and she looked at the monitor and goes, well, yeah, I mean, her coloring's not right, but her vitals on the monitor are fine, so I guess we don't need to ride this. I was like, no, put her on the monitor. Put her on the monitor. And in the end, when we talked about it, she basically said that her preceptor literally looks at the monitor, and if the vital signs are fine, she'll BLS it and go up to the front of the truck. And I'm like, that is the worst fucking possible thing that you can do for a patient. Yes, our highlighter yellow lady, she was fine. I didn't do anything for her except put her on the monitor, but guess what? She's highlighter yellow with no liver history.
Ding, 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 ding.
Like, even if the vitals are fine, it doesn't mean they're going to stay fine. There's a problem here. She might have too much potassium in her system. You might have to give meds. Like,
well, I know you know what I'm thinking about. There's a story when I worked in her facility, had a patient who we were at an outlying hospital, and I think she was in her mid-30s. Like, she was about the age I am now. No history of alcoholism or anything like that. In complete hepatic failure.
ugh.
And she literally looked like someone had dipped her in a vat of iodine. Like, it was the worst jaundice I've ever seen in my life. I see you over there snacking on that. Gotcha. But I, and it was sad. I mean, I hated it. It was a horrible situation. She was not doing well, but altered as fuck. Like similar to your lady, just not coherent at all.
Mhm.
There was no family in the room. It was just I, walk in there for my initial assessment, and the nurse was still doing some paperwork. I don't know if you guys remember those commercials for the Butterfinger candy bars. And it's the little aliens that kind of have this orangey, yellowy orangey glow look to them. And the little tagline is "Nobody lays a finger on my better Butterfinger." So, me being the delightful asshat that I can be sometimes,
Sarcastic.
I walk in and the nurse is talking to me, and she's gonna give me an initial report. And she's like, "I'm gonna get more stuff in your paperwork and whatnot." And I just look at the patient. And I walk up to the nurse and I'm like, "Nobody lays a finger on my better Butterfinger." And she was so taken aback, but she thought it was funny. She didn't know how to respond because she's like, "This is horribly unprofessional, but it's just you and me and this altered patient, and that's fucking hilarious." So, sorry, when you talk about highlighter yellow, that's what I'm thinking of is that particular story.
Well, it's just with our students, especially in the questionable calls, something like that's not very common. How many C-sections are done every day, every month, every year, and you don't often see the postpartum embolism and stuff. I am curious to find out what it actually was, but there was just so much there. And also for the call review purposes, y'all do an appropriate assessment. Don't just look at the patient and be like, oh, well, she's sitting up and yeah, she's altered, but I can't do a stroke assessment, so I don't think it's a stroke. Her vitals are fine, so we're going to BLS it, or we're not going to take this serious. Oh, her last seen normal was at 8 a.m. that morning. And her best friend said that her texting had been off all day, but nobody checked on her until the afternoon when everybody got home from work and stuff. That was a little part that I missed, but
Well, just in general, your OBGYN patients are at high risk for embolisms.
Mhm.
They're at high risk for bleeds. There's so many things because both their literal anatomy and in some cases, they're on a physiological level, there's some pretty significant changes that their body has gone through, whether it was a pregnancy, whether it was a DNC, whatever the case may be. My first blood administration in the field, not like including a helicopter, was a patient that had a DNC and was having hemorrhaging from that. Like massive hemorrhaging. And which was really cool because giving blood in the field is so fucking awesome. But anyway, so take those patients seriously. We especially as guys, we tend to look at OBG calls and be like, ugh, not me, not it. But no, you need to take it seriously. If you're the medic on the truck, you need, not necessarily you have to ride the call every time, just be aware that you have a high risk for those kinds of situations with these patients. Well, kind of jumping into our topic for the night, I want to talk about, we want to talk about elitism in EMS, and I see that there's the low hanging fruit of the difference between the gap between admin and field staff, but even amongst field staff, you have this weird this combination of entitlement and elitism that just work together, and we've beat the entitlement thing to death pretty hard. But
especially amongst certifications like critical care, flight, paramedic, EMT, etc.
So there's kind of two veins that I want to go down, and they overlap a little bit, but I think you'll be able to see the distinction. So the first kind of train of thought is certification versus qualification. And while we were talking about this, I kind of came up with a term that seems fairly relevant to this, and that's certification zombies. It's people who have all these certifications. They have all these accolades that, they can take 3 pages of a document to list them all out for you. But you hand them a shit kicker call and they're often less useful than the regular Joes that just have your normal certifications for the job. And anybody can be checked off to do a class.
Yeah.
And you can jump through the hoops and get the card in your pocket. But that doesn't mean you can functionally do shit. You have to actually be practicing that.
Outside of years of service at a paramedic level, there is no barrier to entry to become an instructor and teach. And the classes, for the most part, are kind of just going over the provider classes, and then also your delivery and understanding that different people learn different ways. So the actual classes, which don't get me wrong, I'm very proud of all the certifications I have. I teach a lot of stuff, but the distinction that Daniel is very much addressing is it doesn't matter what certifications you have if you can't actually do anything. I don't care if you have NRP, if you don't know that the respiratory to CPR ratio or CPR to respiratory ratio. I'm confusing myself. It's
compression
3
to
1.
Ventilation.
There we go. Is 3 to 1. If you're not able to implement that in the field, it doesn't matter that you have the certification. It's whether you can use the certifications.
Because it's okay. Yes, you may have gone and done this cool training and stuff. Awesome. How does that impact your patient care? And that doesn't excuse you from having to have reasonable explanations for what you do. Just because you can say, well, I'm certified in this and this and this. Don't give a fuck. If your clinical judgment is off, I don't give a shit what card you have in your pocket. You're wrong. Period. It's no different than fucking politicians who, okay, just because you have a title that says that you're allowed to make decisions for the country doesn't mean you can't be a dumbass. Doesn't mean you're an expert at everything. You're still fallible. You can still be wrong, and you should be held accountable for it. So this false sense of, oh, I have all these certifications. I'm so much smarter than you peasants down there. Fuck off. I know some EMTs who are a hell of a lot smarter than some of the paramedics I've run into over the years, and that's not an exaggeration.
No, that's an unfortunate true statement.
Like, I don't give a fuck. Like, you're not impressing anybody. It's like the Emperor's New Clothes. Like, nobody gives a damn. You're just walking around naked, and that's all that we see because you make a fool of yourself on calls. Now, that's not to say that everybody who has a bunch of certifications is dumb. Obviously, someone has way more certifications than I will ever dream of having in my life. But you also have jumped through the hoops. You actively do this stuff. You are actively, I mean, we talk about her black cloud all the time, but she actually literally gets the shittiest calls all the time. Anybody who works with her will tell you that. That's not just me saying it. I've only worked with you once or twice, and my white cloud kind of helped us out a little bit. But
we had a gray cloud day, but pretty much anybody. When I was on 24s at one service, I had an EMT partners that would only work with me for like 2 shifts, and they're like, I'm tapping out. I need a break. But I mean, that kind of brings us to a little bit more of it. Even once you become an instructor, even once you become, let's say you get full-time staff of like teaching at whether it's a certification program, a collegiate level, let's say you get a training officer position in a service. I understand there are some technicalities with, being salaried and this and that and all the rest of it. But there's also part-time jobs at other services because I'm sorry, if you are going to teach it for any length of time, you still need to be practicing. I can't tell you how many people I've run into that, have been in the field, had their paramedic for like, 30, 40 years. They've been teaching for like 20, and then, they can spout all of this shit like out of their mouth. But then when it actually comes to talking to them about medicine, or if for some reason they're a bystander on a call that you respond to and they start like suggesting all this random shit and you're like, dude, that's stupid. Like, you would never practically do that. And I think if you're going to teach, especially with keeping up with medicine, you need to be practicing, or it's going to handicap the people that you're teaching. So oftentimes it tells students, oh, a cardiac patient is cool, pale, diaphoretic, because we're wanting them to understand what shock is and that they need to take action. This is an unstable patient. But once they get the concept, at least at my program, we also let them know, like, hey, not every single cardiac STEMI patient is going to be cool, pale, diaphoretic.
Not every patient reads the textbook.
I can't tell you how many STEMIs I've had that the patient looked like they were straining to take the biggest shit of their life. They were like so red, they were turning purple because of blood pooling. Like, you can't not run calls and teach. Like, sure, maybe you're teaching full time and you're part time and only work, 2 shifts a month, but guess what? At least you're fucking doing it. How are you going to teach me how to do an IV if you haven't done an IV in 20 years?
Well, and I think this applies to leadership, because I have heard and seen so many times where, supervisors are like, oh, we spent, this much time or this week at this leadership summit, whatever. I was like, cool. What'd you learn? Like, what? And guess what? We see nothing that actually takes place out in the field as a result from whatever certificate they got from this. It's just like, well, whatever you were taught, it's either completely fucking wrong and it is outdated and ill-informed, or you weren't paying attention and you're not actually doing anything about it. So whatever certificate you got from completing the class doesn't fucking matter.
Well, and also, with leadership if you're going to be in leadership, you need to run fucking calls. You can't just get an office job and be like, okay, I'm done. I mean, there are some supervisors, captains, lieutenants, sergeants, crew chief, whatever they're called at your service. We've seen the ones where they will do anything to get out of a call. They neglect the shift. It's hard enough to get them to bring you supplies, all the rest of it. And then, you have other supervisors like a mama, that will run like every single call with you if at all possible. And, we've worked for one service where I worked for the service for like a year and a half before I ever even met the director over the service. And he walked in and I didn't even know who the fuck he was. I was like, who's this random person walking through the day room? And then we have another service where the director will literally just pop up on calls. Like, you won't even know that he's coming. And all of a sudden he's like, hey guys, what can I do for you? And you're just like, oh my God. It's my boss. And I mean, I'll say the same thing for medical directors. There are some medical directors that I know their name and I've never met them. Dude, I was at one service. I had a really bad Benadryl overdose. It was a 19-year-old who took 5 grams of Benadryl.
God
And
damn.
this dude just comes literally bebopping. Like, literally, he was like...
He's so funny.
He came bebopping in the house. He's like, what you need? And I was like, we're going to get a stair chair. And literally, he was like... And, like, he skipped. This man skipped out of the fucking house and brought me a stair chair. And I look at my partner. I'm like, who the fuck was that? And she goes, that's our medical director. I was like, oh, shit. So anyways, like regardless of whether you're teaching, whether you're a medical director, whether you're in leadership, like you have to be running calls and know what they actually go through. You can't just leave, even down to the drivers. You can't just leave them by themselves.
Yeah. And I think that you see people who move up. There's typically 2 kinds of people that move up. And unfortunately, the latter ones tend to be the ones that are rewarded more. The first kind are the people that actually want to get up and do some good. The people that actually want to make an impact on their people, to try their very best to lead effectively. And nobody's perfect. They're going to make mistakes. Your personality gets in the way of everything a lot of times. So our personalities, we need to be able to adjust. So that's true for everybody. But, you know, those are the people that you really want in positions of leadership, because they're not trying to move up so that they can get out of doing stuff. They're moving up so that they can do more. The second category of people that you, again, typically, these are stereotypes, that you typically see wanting to move up are the lazy people. They want to move up, especially to an admin job, so that they don't have to run calls. They don't have to be involved with people. They can lock themselves away, avoid the problems, avoid the drama, and just, you know, sit at a computer all day and go dick off for lunch break. Unfortunately, those kinds of people tend to be yes men or women. And whereas the first category are like, hey, wait a minute, the little guys need some attention too. The people out there, we need to look out for them. We need to take care of them. And it's like, hang on. Again, very stereotypical generalizations. There's a lot of great services out there that are doing wonderful things and trying to make wonderful things happen. But you can't deny the common patterns, the common trends. So this is something that is a bigger deal. And when you have so many people who have been pushed into leadership who are lazy, who now have a title in front of their name or behind it, depending on the service, they suddenly think that they're all that in a bag of chips.
Well, and those kind of people also don't like to be challenged. And when they get challenged, they fall back on, oh, well, I'm your captain.
You can't talk to me like that.
Yeah, we can't have this conversation. Or
you just got to do what I say.
That's disrespectful. And it's like, even doctors get things wrong. Even the president can get things wrong sometimes. And no one is perfect. No one can, there are plenty of times where, regardless of education, I'll ask Daniel, about a call or something. I'm like, I need your insight. Certification and job title don't mean that you can't be pushed back on. And here's the thing. I think it was either dichotomy of leadership or extreme ownership talked about that when people push back, admit when you don't know, but say that you're going to go find out.
Yep.
The best leaders, yes, lead, but they can also admit either when they're wrong or when they don't know something, and then they go to their leaders or someone that they trust, even if it's lead up, lead down. Go ask somebody else in the field. Let's say, for example, I mean, this would probably never happen, but let's say I got captain because of, or, some kind of higher
shift leader of some sort,
some kind of leadership position.
Yeah.
And I got asked a question. I'm like, well, shit, I don't know that. I could go ask an admin, like a training admin at a different service if I know them. I could come to Daniel because, he's worked at other services and see if he knows something, Google. I mean, obviously you want to make sure it's like scholarly articles, but it's okay to say, I don't know. I'm going to go find out. Not, well, I'm the leader and, we're doing this protocol just because.
Yeah, because it's typically, when you don't have anything actually to back up what you're saying or doing, you fall back on your authority. And yes, I'm a firm believer that the chain of command deserves respect, period. So you shouldn't just come busting balls out, talking shit to your supervisor right off the bat for no fucking reason.
Mm-hmm.
No, that's not appropriate.
Mm-hmm.
Now, obviously, if your supervisor is being unfair, unjust, is harassing you, is being belittling, go for it. Full send. Like, don't go to jail. Don't go to jail.
Right.
But I'm saying yes, you should stick up for yourself, but there's still some level of decorum that should be preserved in the chain of command. However, that is not the stick to beat people with.
Mm-hmm. I've had several supervisors, captains, crew chiefs pick a word that that I respect the position when they tell me like scheduling or, whatever it may be.
Mm-hmm.
I respect that decision, but I did not respect that person as a person.
Yeah.
There's
It's
been a
kind
few
of
those.
it's kind of the age old, like, respect the office, not the man.
Mm-hmm.
And even that I take with a grain of salt. But
Mm-hmm.
the point is, if you're going to have a title, a certification, whatever it is, be willing to back up factually what you say and do.
Mm-hmm.
And if you can't, that is not a shield to keep you from being held accountable for your clinical decisions, your personnel decisions, your judgment calls, whatever. It's not a shield.
Mm-hmm.
It actually is technically a stick to beat you with, because it's more accountability, because you should know fucking better.
Mm-hmm.
But if you don't, guess what? You're human. You should be held accountable by the people beneath you and above you as well.
Mm-hmm. And I just want to reaffirm, your ass should still be practicing. Moving up is not an excuse to not run calls.
Yeah.
Go jump every fucking bad call. Even if all you do is walk on scene and are emotional support for the crew, you at least need to see medicine. Like it.
Yeah.
Moving up a ladder is not an excuse to get off the truck. You still have to be in touch with lower.
Yeah. This is the kind of industry where you can't isolate yourself from the job itself completely.
Mm-hmm.
You shouldn't. And obviously, no, I don't expect a 4-star general to go and, get down in the trenches with an infantryman. But guess what? You should be getting as damn close as you can to that front line, and let people see you, and let people see that you know what they're dealing with and what's going on. Don't stay locked up in the ivory tower. Don't hide in your fucking office behind your desk.
Well,
get out there with your people.
Well, and with you making that comparison, there's also a lot more levels and certifications and jobs within the military. Paramedicine is not that hard.
It's really not.
Like
it's not rocket science, people.
Well, when I'm talking about, like, I mean, yes, medicine can be hard. You get some kicker calls, but what we're referring to is it's not like there's 100 certifications and 50 million jobs and you're spread across multiple states and stuff like that. So like if you are a corporate company, like, sure, you need to go visit the independent like services maybe that you own, but like within that service, the director is not that high above field staff. It is possible to take a day, even if you only run one shit kicker call that was close to you. Within EMS, it's not as hard as, a 4-star general or whatever. Like, go fucking do something.
Now, kind of segueing off of that topic was more of dealing with, titles, certifications. This next vein is talking about experience versus expertise. Because you have a lot of people who are like, well, I've been doing this for, 30 years, so I know some things. And
I'm not going to lie. As soon as somebody says that to me, I automatically assume that they're stupid. And I don't mean that hateful, but like if you have to fall back on your years of service to justify something, like that's the first thing out of your mouth, just like a certification. Oh, well, I have XYZ certification. It's like, okay, that's not what I asked. Like I asked a question. Or, if you're doing bad patient care, you go, oh, well, I have 20 years of experience. Like, okay, so you've had 20 years to be stupid. I think one of my favorite quotes that I've heard from somebody is, let's take 20 years, for example. It could be 5 years, it could be 2 years. I don't fucking care. But for this example is 20. Have you really worked for 20 years, or have you repeated your first year 20 times? And the meaning behind this is, I don't care if you've worked for 20 years. If you have not done anything to expand your knowledge, to to continue your education, to better yourself, move up in leadership, do something to increase your ability to give good quality patient care, or as we call it, clinical discipline, and rigorous accountability, then you're basically just a first year. You're an old first year. You're, a kindergarten repeat.
Well, and an example I like to think of is when I was a kid, we used to go hike up in the White Mountains in New England. It was just a favorite family vacation spot. There was one hike in particular, and I've always said it is the best difficulty to reward ratio you can ask for. It's like a mile and a half long hike, but the view is incredible. So if I just did that hike, let's say I did it every day for 20 years, cool. I'm not ready to go climb Mount Everest.
You're really good at hiking a mile.
I'm really good at hiking that mile and a half. And okay, sure, maybe I occasionally switch it up and I go to a hike that's like 2 miles or 3 miles or whatever. That doesn't mean I'm ready for Mount Everest. Mm-hmm. So just because you have done a kind of thing for a really long period of time doesn't mean that you have been challenged in any way. That doesn't make you an expert on shit. It just means you've done it for a while. Cool. Mm-hmm. Now, in that time, let's say let's compare that. I'd say I did that hike for 20 years, every day for 20 years. Cool. Well, let's bring along somebody who has only been hiking for 5 years, and they started with, say, a little like, half a mile hike, but then each week they went and hiked more and bigger mountains, longer trails, more difficult trails. That person in 5 years is going to have more experience, more competence, more knowledge, practically and, academically, you could say.
Psychologically.
Yeah. They're going to be better prepared than me doing it for 20 years.
Mm-hmm.
So this whole claiming to be an expert simply because of how long you've done the job is horseshit. Complete and total horseshit.
Let's take something as simple as IVs. I've seen medics that have been practicing for 20 years that literally it's a 20 in the left AC every single time. And if they get a patient that doesn't have an AC or, has valves, or they do the AC and then they blow it, then it turns into, oh, well, I wasn't really going to use it anyway, so it's fine. And it's like, okay, dude, I've started thumb IVs.
Mm-hmm. I've started boob IVs.
Yeah, I need to do a boob IV, but I love feet. God,
Not like that, you perverts. Shut the fuck up. I know where you went.
I think I shared it on TikTok. I had a DKA patient that was also a dialysis patient. I started in 18 in the arch of his foot. For the record, he was unresponsive.
Oddly satisfying.
Right. But if you're somebody that regardless, right, even if you've been doing IVs for 20 years, if it's 20 in the left AC every single time, you're not going to be proficient at thumbs or, God, I love a good wrist IV. Or let's take an EJ. You learn how to do EJs in school, but if you don't know the angle and how to turn the head and pressure and all the rest of it, you can give them an air embolism. I don't care how many times you practiced one skill or one thing.
Well, and being an expert requires not just that you commit time to learning and doing something, but that you are continually challenging, pushing, and expanding your knowledge base. And ultimately, especially with a job like this, and we've touched on this before, but I can't emphasize it enough, your ability to expand and strengthen your intellect, generally speaking, not even just with medicine, because I think we sometimes get hyper fixated on, I have to just study medicine, I have to just do these things. No, go read books about philosophy. Go read books on business and the economy and all these things. Push your brain. Yes. Psychology.
That's not pop sci.
Yes. Actual good quality material. Go push your brain on those things. And the more you stretch your brain, again, it's a muscle. The more you stretch that brain, the more capability it's going to give you, so that when you're doing medicine, when you're making assessments, your brain is able to make more connections faster, more effectively than you would have if you never cracked a book on anything.
Well, so I know it has to do with medicine, but let's refer back to the call review. whether it's EMT or paramedic school, the amniotic embolism risk is not super common. We want to be an expert in our field, but you need to continue, like Daniel said, learning. You have to learn about subtopics. So, with OB patients, you're not taught about the amniotic embolism, but when you hear something, whether it's on TikTok or social media or read it somewhere or somebody just mentions it, go look it up. Go look it up. Even if you will never see it because that's a relatively rare occurrence, go look it up, because then, just like with my patient, it's something that you can consider as a differential diagnosis. I did some research on Chiari malformation at one point. Well, lo and behold, 4 or 5 years later, I was called out to a sick person, and I walk in and the patient is writhing in pain. We're like, okay, what's going on? What's your medical history? Well, I have Chiari malformation. Literally, as soon as she said that, I knew exactly why she was in pain. I knew the pathophysiology behind it. Even if it's not something that will change our treatment, it's just knowing about it. I mean, I also think medicine's cool. I think medicine's cool. But Daniel, you talked about it in one of our other podcasts, the what kind of tissue was it? The endometrial tissue in the lungs.
Yes, I can't remember the name of it. But it was a patient who, so we got on scene, and fire department comes out to give us a report, and both my partner and I are like, bullshit. Because literally the first words out of this firefighter's mouth are, yeah, she has a pneumothorax every month with her cycle. And I was like, excuse the fuck out of me? Combination of what the fuck, this is bullshit, and pucker factor of what if this is fucking real?
Yeah.
Because we were called out for shortness of breath and chest pain. Well, thankfully it wasn't her cycle. So we were very glad about that. But she educated us that she is one of a very, very select number of patients worldwide that has this particular pathophys, where she has endometrial tissue in her lungs. And so when she has her cycle, she also gets a pneumothorax, legitimately. And that was something where she was able to educate us initially. And then after the call, my partner and I were like, this can't be fucking real.
Yeah,
what the fuck? So we started Googling, and we're like, holy shit, it's actually a thing.
It's a thing.
What the fuck? So yeah, you have to be willing to be pushed a little bit and be uncomfortable and acknowledge that you don't know everything. But I have this, I hate it when I hear people who are like, oh, well, I've never heard of that before, so it can't be a thing. Excuse the fuck out of me.
I mean, doctors have specialties for a reason. And honestly, there are times where, I'll have a conversation with a doctor and he's like, oh,
yeah,
I mean,
news to me.
That happens.
And that's why it's good to follow up with your patients too. Not like, oh my God, I need to follow up with this patient that was so horrible. No, if you ran into some weird medicine,
following up.
Yeah, follow up clinically, see what the fuck happened. And just people who use their years of service to say, you shouldn't question me. You're insecure, and more than likely you're incompetent. Because if that's the best excuse you have to combat somebody questioning your judgment, that's kind of telling. We can smell the bullshit.
Yeah, I mean, I've been doing this for 20 years, and my decision is final. It's okay, if somebody's going to ask me something, I'm going to use medicine and facts and differential diagnoses. I can't remember if we've talked about it, but I had a hypocalcemic patient that I technically sort of kind of stretched protocol for. But there was only one listed protocol I could list it under, which is hyperkalemia, even though she wasn't hyperkalemic. And I got questioned about it by the QA team, because they're like, hey, this protocol doesn't match up with the patient, blah, blah, blah. Your narrative's really thorough, but tell me more. And instead of, oh, well, I've been doing this for blah, blah, blah. And oh, I have all these certifications and blah, blah, blah. I was able to clinically explain why. And that's what we're supposed to do. Whether it's being challenged because, smarter, more experienced people in education, QA, whatever, are looking at it going, hey, this doesn't quite make sense. Or what if it's an EMT or a new paramedic that is trying to learn? It shouldn't just be, it's because I said so. We're doing this just because. You need to be able to back it up. And that is honestly true for anything in life. You can't just make a decision and be like, oh, it's because I'm female, I do this. Or, oh, it's because I'm a mom, I do this. It's okay. Why?
Yeah. Even, I mean, hell, even as parents with your kids.
Mm-hmm.
And I understand, yes, there are times where you just have to make an executive decision because a decision has to be made. And you just have to tell them, hey, suck it up. This is just the reason we're going to do this, right here, right now.
Mm-hmm.
But if you're going to make something an issue chronically, if you're going to make it especially an issue, whether discipline's involved in some capacity or whatever, in an age appropriate way, you should explain to your kids why you're doing something.
Mm-hmm.
We make an effort to do that as much as possible every time. And you will actually have a better relationship with your kids if you do that, because they're going to see, sometimes you make mistakes and you have to call yourself out, but also they will learn to think critically and to think beyond the moment to ramifications of actions.
Mm-hmm.
Same thing applies in medicine. If you have to make an executive decision, explain why. It's okay to make executive decisions. It's fine. Sometimes you have to. But if you're going to do that, you need to be able to back your shit up. You also need to be willing to be challenged because, and again, making the analogy to parenting, I've had examples of that very recently where, there was a little bit of pushback of, well, normally whenever, I say this, you say this in response. That's why I didn't say anything. Okay, I was wrong. Let me clarify. Here's the way things should happen. Same thing on calls. Is be willing to be challenged. And if they're right, fucking admit it.
Mm-hmm.
Build them up. Don't sit there and make a fuck ton of excuses. Just acknowledge it and be like, hey, I'm glad you caught that. I wasn't thinking about, whatever it is. I didn't notice that. Thank you for catching that. Thank you for helping out. Because guess what? That's patient-centered. Mm-hmm. That's not ego-centered. That is centered around your patients and their outcomes.
Well, and people with their egos, don't like to be challenged. They don't like to be humble.
No.
They don't like to be humble.
You can be humble and still be confident and competent,
mm-hmm.
but you should still be humble too.
Mm-hmm. And even if you're expert level, I mean, there's plenty of people that admit that they don't know anything. I mean, again, I know it's low-hanging fruit, but doctors are experts at one particular system or organ or, whatever it may be.
Yeah.
Doctors are experts, but they can still be wrong. I mean, doctors consult each other all the time. Just because you complete medical school, those docs still have, how many years of residency, and if they're going to surgery, how many years of, that and all the rest of it before they can become, practicing attendings. And even then, they tend to lean on each other because even doctors will see shit that they've never seen.
Mm-hmm. So, at the end of the day, nobody's perfect. Going to make mistakes. We need to continue learning every day because this is a dynamic field. Medicine is always changing. Mm-hmm. There's new shit that's come out since I finished paramedic school. And that was less than 10 years ago. It's always changing. So always be willing to learn. You can't learn everything. You can't master all of it. It's not possible. You can't be, yes, you can technically become a master and expert of the paramedic scope of practice. But
even that's expanding. You
can't
even claim that anymore.
We're going to start seeing more specialized types of paramedics out there soon. And hello, Noodle. You had to have the center of attention. He looked like he was having an existential crisis behind you earlier. He just sat there looking at the window like can't see shit. Anyway, we're going to start seeing lots of other kinds of paramedics show up because there's so much now that is included in the paramedic scope of practice. So be humble. Stop being shitheads to each other. Stop acting like fucking toddlers. Show some professional courtesy. Earn some respect. And carry on with your day. You don't have to have an opinion about everything. You don't have to correct every single person all the time. Mm-hmm. You don't need to one-up people all the time. Listen to them. You might learn some shit if you weren't so concerned about being right or justifying your own laziness.
Yeah.
Got anything else you want to throw in here?
If you are in education or any kind of leadership, literally, even if it's only one step above being a field provider, a sergeant, a captain, a crew chief, what the fuck ever, run calls. Don't be lazy. Don't just assume that you automatically get that. And, don't assume that the rules and regulations and respect and everything no longer apply to you, including sleeping with coworkers on shift.
In company vehicles. Anyway.
Yeah.
If you learned something, good. Tell your friends about it. If you were offended, good. You probably should be. Fix your shit. And we'll talk to you next time. Bye-bye.